Hello everyone. I'm Vedic Gautam, a PharmD fourth year student, and I'm going to talk about a topic that is rheumatic fever today. So, what is rheumatic fever? Right. Rheumatic fever is an immunologically mediated inflammatory disorder. Right. It is caused by immunological response. Okay, which occurs as a sequel to Group A streptococcal pharyngeal infection. Now, Group A streptococcal pharyngeal infection is also known as GAS infection, which we will see in further slides. Right. Now, multi-system disease affecting the heart, joints, brain, cutaneous, and subcutaneous tissues. Okay. Acute rheumatic fever remains an important preventable cause of cardiac disease because it is also affecting heart and the way it affects heart, the process is irreversible. So we can prevent many cardiac diseases which is caused by this. Okay, it is most common in children who are 6 to 15 years old, right? But it can also occur in adults. Okay, a family history of rheumatic fever and lower socioeconomic status are additional factors to this. Okay, now we are going to focus on pathogenesis of rheumatic fever. Okay, now, rheumatic fever is caused by streptococcal infection, right? And streptococcal infection is just like strep throat. It is affecting your pharyngeal portion and tonsils. Okay. Now, it is hemolytic streptococci. Now, what happens is, as this infection affects the pharynx of human, then a immunologic reaction occurs inside the body. Antigens are there, so antibodies are produced. Okay, it can take up to 2 weeks, 6 weeks, 10 to 14 days later, right? Now, which parts or which organs it is affecting? Okay, it is affecting joints, heart, skin, and nervous system. Okay, now let's read this out. There is no direct invasion to the tissue by the microorganism, right? But it's an autoimmune disease that involves antigen antibody interaction, right? Means इसके अंदर direct interaction नहीं है. uh, Streptococcus is not directly interacting with these organs. Okay, the main thing that is interacting with these organs is this antibody which is produced because of this antigen that is given by streptococcus infection. Okay, now it is due to an immunologic reaction that is a delayed sequela of group A beta hemolytic streptococcal infections of pharynx. Okay, it must be pharyngeal infection, not skin infection. Okay, so streptococcus infection should occur in pharynx to cause rheumatic fever. It should not be skin, right? Now, what is actually happening with group A streptococcal pharyngeal infection? Okay, now body produce antibodies against strep. Okay, body is producing antibodies against streptococcus or strep throat, right? Now, these antibodies cross react with human tissues. Okay, because of antigenic similarity between streptococcal components and human connective tissues, molecular mimicry. Okay, now remember these two words which we studied above: cross react, and molecular mimicry. These two words play with whole pathogenesis of this rheumatic fever, right? The organs or the streptococcus is actually mimicking the organs, right? It is showing molecular mimicry and it is showing cross reactivity, that is antigen and antibody reactivity, right? Now, there is certain amino acid sequence that is similar between GAS and human tissue. Okay. Now, this protein which we are talking about here is actually, you can see in this photo of streptococcus pyogenes, the outermost layer, these filaments M protein in fimbriae, and these adhesins M protein, lipotecoic acid, and protein F and SFB. Okay, this M protein and these things are present in heart, in cardiac muscles, in skin, in joints, in hyaluronic acid, and in brain. Okay, so these are the things which affects because of this M availability of M protein. This is how it is mimicking the organs, right? Now, remember these three invasions, okay, written in this bottom left corner, that is streptolysins, streptokinases, and proteases. Okay. Now, immunologically mediated inflammation and damage, autoimmune, to human tissues which have antigenic similarity with streptococcal components like heart, joint, brain, connective tissues. Okay. Now, clinical manifestations. We studied about pathogenesis. We understood the pathogenesis. It is all about antigen and antibody interactions, right? Now we are going to focus on clinical manifestations. Okay, the infection often precedes the presentation of rheumatic fever by 2 to 6 weeks. Okay, it can occur after 2 to 6 weeks of a strep throat. Okay, now acute rheumatic fever is diagnosed using the revised Jones criteria, which consists of clinical and laboratory findings. Okay. Now this Jones criteria was given by Dr. T. Ducklet Jones in 1944. Okay. It was revised by AHA, American Heart Association, in 1965. Okay. Now, and latest revised Jones criteria was given in 2003, which we are going to study now. So there are one major criterias and there are one minor criterias. Okay. Now, what are the major criterias in Jones system for acute rheumatic fever? Okay. Now, the first one is polyarthritis. It is common thing which includes swelling, limited motion, tender, and erythema. Okay, it is migratory. It affects large joints, no residual deformity, rapid response to aspirin. Okay, if aspirin given 24 to 48 hours, joint pain will disappear. Thus, use just diagnostic test. Right. So polyarthritis, which is also called migratory polyarthritis. Okay. Now carditis. Carditis involves pancreatitis, valves, pericardium, and myocardium. Pancreatitis is infection of whole muscle. Okay. Now, what we can see in carditis, right? We can see that it will show murmur, mitral or aortic regurgitation, endocardium involved, right? Heart failure, cardiac enlargement, which involves myocardium, and pericardial rub or effusion, which involves pericardium, right? Now we have chorea or Sydenham's chorea, okay, uh, which presents long after infection has resolved, more common in females. It is spasmodic, unintentional, and jerky coriform movements. Okay, speech is affected in this, and it shows late manifestations like it is we cannot see in early rheumatic fever conditions. Okay, then we have erythema marginatum. Okay, it shows pink macules, ring or crescent shaped transient patches over trunk and limbs elicited by application of local heat. Non-pruritic. Okay, we are going to see a photo of erythema marginatum here. You can see these central clearing rings. Okay, these rings, these are erythema marginatum. We can see in the patients with rheumatic fever. Okay, it is used for diagnosis. Okay, now, the last one is subcutaneous nodules, which is painless, hard nodules beneath skin, over bony prominence, tendons, and joints, present over extensor surface of elbows, knees, knuckles, and ankles, or scalp and spine, associated with repeated episodes in severe carditis. Okay, now here you can see these are two subcutaneous nodules. You can see it. Let me show you. These are the subcutaneous nodules. You can see this one and this one. These are subcutaneous nodules. Okay. Uh, Now we are going to see what are minor criteria here. Okay. So in revised Jones criteria, we have minor manifestations which include fever, arthralgia, increased PR interval ECG, and ESR or CRP levels are increased. Right. We have seen major manifestations, which is carditis, arthritis, Sydenham's chorea, erythema marginatum, and subcutaneous nodules. Then we have seen minor manifestations, which shows fever, arthralgia, increased PR interval on ECG, and increase of ESR and CRP levels. With these two criteria, we are going to involve GAS, that is Group A Streptococcus infection. And for that, what we are going to do, we are going to test on throat swab, culture test. Then we are going to take anti-streptolysin O titer and anti-deoxyribonuclease B, anti-DNase B. So for diagnosing through these Jones criteria, the patient should have either one major or two minor with this gas infection, okay, or two major with evidence of recent Group A streptococcal disease strongly. It suggests the diagnosis of acute rheumatic fever, right? Now, this how to see evidence of recent Group A streptococcal disease. The patient would be suffering from scarlet fever, or there would be a positive throat culture. It is seen in 25% of patients. And then we are going to do rapid streptococcal antigen test. We can do it, which shows elevated or rising streptococcal antibody titer, ASO, that is anti-streptolysin, or anti-DNase B, or AH, that is anti-hyaluronic acid, right? Now we are going to focus on treatment strategies. Treatment strategies involve four steps. The step one is primary prevention, which involves eradication of streptococci. Okay. Second step involves anti-inflammatory treatment, which includes aspirin and steroids. Step 3 includes supportive management and management of complications. And step 4 includes secondary prevention, prevention of recurrent attacks. Okay. Now, what is the treatment? Treatment includes bed rest 2 to 6 weeks till inflammation subsided. Right now, supportive therapy. That is our step. There is a step in treatment. Okay. Now, what is supportive therapy for rheumatic fever? It includes eradication of organism, anti-streptococcal therapy. It includes benzothine penicillin, long-acting, 1.2 million units once intramuscular injection, or oral penicillin for 10 days. If allergic to penicillin, then we are going to prescribe erythromycin 10 days. Antibiotic is given even if throat culture is negative. This is supportive therapy. We are going to give anti-inflammatory therapy to the patient now for inflammation caused by immunological processes. This includes for polyarthritis and mild carditis, we are going to give anti-inflammatory therapy with salicylides, which includes aspirin 100 mg per kg per day for arthritis. Aspirin 100 mg per kg per day for arthritis, and in the absence of carditis, for 4 to 6 weeks to be tapered off. Okay. If we cannot see carditis there, then for 4 to 6 weeks we are going to give aspirin, and then we will gradually decrease the dose and we will cessate the drug. Okay. For severe carditis with cardiomegaly, use steroid corticosteroids 1 to 2 mg per kg per day for 4 to 6 weeks to be tapered off. Okay. If there is severe carditis with cardiomegaly, then we are going to use corticosteroids, which is 1 to 2 mg per kg per day for 4 to 6 weeks, and we'll then gradually decrease the dose and cessate the drug. Now, prevention, secondary prevention, prevention of recurrent attacks. Secondary prevention, prevention of recurrent attacks. Benzathine penicillin G 1.2 million units IM every 4 weeks is given for secondary prevention or prevention of recurrent attacks, or penicillin V 250 mg twice daily orally. Okay. If the patient is allergic to both benzathine penicillin and penicillin V, then we are going to prescribe erythromycin 250 mg twice daily orally for prevention of recurrent attacks. Now, duration of secondary rheumatic fever prophylaxis. If rheumatic fever plus carditis, then we are going to give the treatment for lifelong. If rheumatic fever without carditis, then we are going to give the treatment in 5 years or until 21 years, whichever is longer. Continuous prophylaxis is important since patient may have asymptomatic GAS infection. Continuous prophylaxis is important since patient may have asymptomatic GAS infection. Okay, GAS infection can be asymptomatic. Okay. So now we are going to discuss about prognosis of rheumatic fever. Okay, rheumatic fever may cause permanent damage to the heart, but not to the joint. Only arthritis. Thus, it said RF leaks the joints but bites the heart because the cardiac involvement in rheumatic fever and the damage to cardiac muscle is irreversible. Right, it cannot be reversed if the damage occurred in cardiac muscles. Okay, the prognosis of acute rheumatic fever depends on the degree of permanent cardiac damage, because if there is inflammation in joints, it can be cured by giving aspirin and other anti-inflammatory agents. Okay, but the damage to cardiac muscle can be a can be a degree to count on rheumatic fever, or to count the prognosis of rheumatic fever. Okay? Cardiac involvement may resolve completely, especially if it is the first episode and the prophylactic regime is followed. If there is no permanent cardiac damage or there is no muscle damage, then this immunological response can be cured by providing the prophylactic treatment, or by following the prophylactic regime. The severity of cardiac involvement worsens with each recurrence of rheumatic fever. Okay? With each recurrence, the cardiac damage occurs, and the cardiac condition worsens. Okay. Now, what all we studied in this is, we first focused on etiology, or what is the rheumatic fever. Right. Rheumatic fever is nothing. It is just It is just caused by streptococcus infection or group A streptococcus infection, and it is an autoimmune inflammatory disease, right? It can occur to 6 to 15 years old. It can also occur in adults. Uh, Now, then we studied about rheumatic fever pathogenesis. We talked about hemolytic streptococci. Actually, hemolytic streptococci isn't causing the infection at first. Hemolytic streptococci is causing the infection at first, but actually the rheumatic fever is occurring due to the immunological response or the mimicry or cross reactivity uh, that occurred, right? Uh, we discussed about the pathogenesis. It is generally about antigen and antibody interaction. Then we talked about group A streptococcal pharyngeal infection, that how the body produced antibodies against strep. Then these antibodies destructed its own cells by because of the mimicking activity of streptococcus, group A streptococcus infection. Then this is how streptococcus pyogenes looks a label diagram, and the main parts which are mimicking our organs is M protein. This M protein is a group of amino acids which is found on these major five organs, that is cardiac, skin, and subcutaneous, and joints, and brain. Okay. We have studied about clinical manifestation that it can take up to 2 to 6 weeks after any step to occur a rheumatic fever, right? We have discussed about major criteria which were involved in which were given by Jones, and these criteria were polyarthritis, carditis, chorea, erythema marginatum, and subcutaneous nodules. Uh, this is how these two looks: subcutaneous nodules and erythema marginatum. Then we discussed about minor manifestations and gas infection. Minor manifestations include fever, arthralgia, increased PR interval on ECG, and increased ESR or CRP. Okay. Now just don't confuse between these two. In major and minor manifestations, it is written arthritis and arthralgia. Okay. Arthritis is inflammation of joints, whereas arthralgia is pain in joints. Okay. So these two are different. Okay. Then we have seen gas infection, for which we can test gas on throat swab. We can do an anti-streptolysin O titer test. We can do an anti-deoxyribonuclease test. Okay. For diagnosing the patient with the help of this criteria, there should be one major or two minor present or with a gas infection, or there should be two major with evidence of recent group A streptococcal disease. Okay. Then we have discussed general evidence of streptococcal disease. We have discussed the strategies involved four steps, which were primary prevention, anti-inflammatory treatment, supportive management, and management of complication, and secondary prevention. Okay. Then we discussed about treatment. And treatment we were giving, uh, we were focusing on these main drugs, which were benzathine penicillin G, and erythromycin if the patient is allergic to this. Okay. Uh, then we focused on prognosis, which in which I included about major points about cardiac involvement and why the cardiac involvement is necessary for diagnosing and prognosis of rheumatic fever. Thank you everyone for giving me your precious time.